Hi everyone, welcome back. We're going to talk about how diuretics work, and we're also going to talk about sodium balance by the nephron. There's a lot of high yield content we're going to cover here, so let's get started. All right, so let's start with an overview of diuretics. We've all heard that coffee is a diuretic, alcohol is a diuretic. So what is a diuretic? A diuretic is basically anything that makes you pee more. So it increases urine volume and rate, and as a consequence, if it continues to do that, you're going to have a decreased fluid volume in the body. And we have diuretic medications that are very, very important, and their main uses are for hypertension and edema, which is excessive body fluid volume. Now you can divide the mechanism of these diuretics into two major categories. So by far, the vast majority of diuretics, almost every single diuretic I've ever seen a patient on, work by decreasing the serum sodium levels, and that's going to be most of this talk. There's just one class that works through a different mechanism. Those are known as osmotic diuretics. These are agents that directly pull out the water, so they don't involve anything with sodium. So I'm going to talk about these at the end as well, but we're going to start off with the ones that are going to affect the body's sodium. All right, so to understand body fluid volume and the effect of diuretics on blood pressure, there are 5 important facts that you need to understand. So number 1, sodium is the most abundant ion in the plasma. So when you get that Chem 7 or that electrolyte panel and you're looking at your ions, you're going to see the one that has the highest reference range is the sodium. The reason that's important is because since it's the most abundant ion, it's the one that's going to have the greatest osmotic effect on how much water is in the plasma. So sodium is the main ion that's responsible for pulling water into plasma and for determining our intravascular volume, which then directly determines our blood pressure. So in this way, the sodium content in our body is directly proportional and relevant for determining our blood pressure. So for example, if we have an increase in the total body content of sodium, this is going to pull in more water into the plasma and is going to increase our blood pressure. And clinically, this is important because this is why we tell patients with high blood pressure to avoid salty diets. On the other hand, we have a decreased total body content of sodium. This can lead to decreased blood pressure, and clinically, this is important because this is the main mechanism of action of most diuretics. They decrease the total body content of sodium. The final point here is that the body content of sodium is very tightly regulated by the nephrons, and so to understand this better, we're going to walk through the nephrons and see how sodium reabsorption is regulated at each step. All right, so that means that we have to get into the kidney. So you remember from other videos that a nephron can be subdivided into the renal corpuscle and into the renal tubule. So the renal corpuscle is where you have the glomerulus and the Bowman space, and this is where filtration is happening. Sodium is freely filtered through the filtration barrier. What that means is that the concentration of sodium in blood, which is in the glomerulus, is going to equal the concentration of sodium, which is in the Bowman space. Now, obviously, we don't want to lose all of that sodium that we just filtered, so we need to get some of it back. So what that means is that in the rest of the nephron, which is this renal tubule, we have to work at getting some of the sodium back into our bloodstream. So now let's quickly work through the different parts of the renal tubule. We have the proximal convoluted tubule, which then goes to the descending limb of the loop of Henle, and then you have the thin ascending limb of the loop, and then the thick ascending limb, small letter T for thin and capital T for thick, and then we have the distal convoluted tubule, and then finally the nephron ends at the collecting duct, which are going to collect all the filtrate and drain into the collecting system. In this renal tubule, there are primarily 4 sites where we have specific channels that are dedicated to sodium absorption, and those 4 sites are the proximal convoluted tubule, thick ascending limb of the loop of Henle, the distal convoluted tubule, and the collecting duct. So what we're going to do is we're going to go through each of these 4 sites one by one, identify the channels, see how they work, and then see how the diuretics are going to act on those channels to prevent sodium reabsorption and therefore lead to diuresis. All right, so let's start with our first of the 4 sites, which is the proximal convoluted tubule. And I'm going to talk about this in a second, but you notice that I added colors here. So blue indicates the cortex and gray indicates the medulla. So this means that the loop of Henle and the collecting duct are located in the medulla. Everything else is located in the cortex, and this will become important next when we talk about the loop of Henle. But for now, we can just continue on talking about the proximal convoluted tubule here. Let's zoom in on one of the cells that lines the proximal convoluted tubule. And on this side, we have the apical side, which is facing the lumen. So this is where we have urine or filtrate that came from the Bowman space. And on the back side, this is the basolateral side, and this is in red because this is where we have the blood or the peritubular capillaries. As you can see here, we have a few different channels, so let's see how this is important for sodium handling. Most of the electrolytes, as well as all of the glucose and amino acids that were filtered out in the glomerulus, are going to be reabsorbed in the proximal convoluted tubule. And regarding sodium, most of the sodium reabsorption, so approximately 2/3 of the sodium reabsorption is going to take place right here. The channel that's responsible for this is known as the NHE. So this stands for the sodium hydrogen exchanger, specifically type 3. Exchanger means that the sodium and the hydrogen are going in different directions. So the sodium is being reabsorbed into the cell while the hydrogen is being kicked out. Now, this hydrogen that's being kicked out isn't coming out here aimlessly. It's actually very important for doing a very specific job, fishing out bicarb. This proton grabs a bicarb, and this bicarb came from being filtered out way up here in the glomerulus. And so this proton is going to bind to it. And then carbonic acid is going to turn into CO2 and H2O by the enzyme carbonic anhydrase. So this is a very important enzyme. What's going to happen to this CO2 and H2O is that they can both diffuse and get into the cell. And once inside of the cell, they can actually do the reverse reaction, which is again mediated by the same enzyme carbonic anhydrase, and reform carbonic acid, which is H2CO3, and then that's going to break down into proton and bicarb. And now this sodium and bicarb that we absorbed from the lumen is going to be reabsorbed and get into the systemic circulation, whereas that proton is just going to be recycled by this NHE channel and fish out another bicarb and allow for reabsorption of another sodium. And the net effect is going to be reabsorption of sodium and bicarb into the body. And the key diuretic that's going to affect this process and inhibit sodium reabsorption is called acetazolamide, and we're going to talk about that next. All right, so now let's describe the diuretics that work by inhibiting sodium reabsorption at the proximal convoluted tubule. The main drug here is acetazolamide. The mechanism of action here is actually not inhibiting the sodium proton exchanger, so don't get tricked by a test question that offers you that as the option. The actual mechanism is that they're inhibitors of carbonic anhydrase, but by doing that, secondarily, they're going to disrupt the actions of the sodium proton exchanger, so the net effect is going to be a decrease in sodium reabsorption and in bicarb reabsorption, because remember, that was the other ion that was getting reabsorbed as a consequence of the actions of these channels and enzymes. So this decrease in bicarb reabsorption is of course going to cause metabolic acidosis because we have less bicarb in our serum and in our body. And so the main indication actually for using these drugs is to take advantage of this side effect by using this medication to prevent altitude sickness. So essentially what you're doing is you give a person this medication, you're going to induce some metabolic acidosis. So to compensate for that, they're going to hyperventilate. And this hyperventilation is actually going to be helpful for them when they go up in altitude because the atmospheric pressure and the levels of oxygen are lower. So hyperventilation is going to help them get more oxygen and prevent altitude sickness. The other major indication for using acetazolamide or these carbonic anhydrase inhibitors is because they actually have an important role in production of fluid in the eyes and the brain, and therefore by inhibiting it, you can reduce production of this fluid. So they can be used for treatment of glaucoma. Glaucoma is a condition where you have an increase in the intraocular pressure, and what acetazolamide does is it actually reduces the production of the fluid in the eye, which is known as aqueous humor. This is going to lead to decrease in eye pressure and treatment of glaucoma. And for the brain, there's a condition known as idiopathic intracranial hypertension. So you can tell from the name, intracranial hypertension means elevated pressures in the brain. And so the way that acetazolamide works here is that it reduces the production of fluid around the brain, which is the cerebral spinal fluid or CSF. And therefore, with less fluid, we're going to have a decrease in intracranial pressure. So these are the other two main indications for using acetazolamide. It is not a commonly used medication for generalized systemic hypertension or CHF. These are really the main indications for using it. Okay, now let's talk about the side effects. So first one we already talked about, it can cause metabolic acidosis because it decreases bicarb reabsorption. We talked about it up here. It can also lead to the formation of kidney stones, and you have to follow the logic here a little bit, but it makes sense. So by reducing bicarb reabsorption from the urine, that means that the urine is going to be more alkaline because it has more bicarb in it. If it's alkaline, that means it has less protons in it. And if there's less protons, which are cations, that means the phosphate, which is an anion, is more free to bind another cation, and that one is going to be urinary calcium. And as it turns out, when calcium and phosphate bind to each other, they can actually form salts or stones and precipitate out, and this leads to the formation of kidney stones. And the final important side effect of these drugs is hypocalcemia, or a decrease in the serum potassium level. The reason this happens is because of increased ENaC action in the collecting duct. So what happens is that since we're not reabsorbing sodium in the proximal convoluted tubule as much, that means that there's going to be a higher sodium load that's going to be delivered all the way to the distal nephron, to the collecting duct. And when it gets there, it's going to increase the activity of these channels known as ENaC channels, which are special sodium channels that I'm going to talk about in a little bit when we get to the collecting duct. In addition, the use of these diuretics is going to cause some dehydration and activation of RAS, and the aldosterone part of the RAS pathway is also going to stimulate this ENaC action. And so one of the consequences of the increased action of these sodium channels is that in response, we're going to get increased secretion of both potassiums and protons into the urine. And since we're increasing the secretion or getting rid of more potassium into our urine, our serum potassium level is going to go down and we're going to get hypocalcemia. This is going to be a common side effect that you're going to see in all of these diuretics that are working upstream of the collecting ducts, because they're all going to lead to this increased sodium delivery to the collecting ducts and increased ENaC action leading to hypocalcemia. Now you may be asking, if we also have increased proton secretion, why wouldn't we end up with metabolic alkalosis from proton secretion? And the reason is because in this case, the direct actions of the drugs outweigh that, and the metabolic acidosis caused by an impairment of the bicarb reabsorption and the proximal convoluted tubule is greater. So when it comes to pH, we end up with metabolic acidosis because of the decreased bicarb reabsorption. And when it comes to potassium, we end up with hypocalcemia due to increased potassium secretion as a consequence of the increased ENaC actions in the collecting ducts. All right, so now let's get back to our nephron and move on to our second site where we have sodium reabsorption. So we're all done up here in the proximal convoluted tubule. The descending limb is only important for water reabsorption. The thin ascending limb does not have a major role here. So the next major role, and the one we're going to talk about here, is the thick ascending limb of the loop of Henle. And here we have important sodium reabsorption channels. So let's zoom into our cells just like we did last time. So again, we have the apical or lumen side, which is yellow for urine. So this is where the filtrate is. And on the back, we have the basolateral side with the peritubular capillaries, blood, and the rest of the body circulation. And the channel here that's important for sodium reabsorption is known as NKCC. So the Na, which is sodium, K for potassium, and chloride cotransporter. So that's what NKCC stands for. And what happens here is that it is a cotransporter. That means that all of these ions are going in the same direction. All of them are being reabsorbed. So we're reabsorbing one sodium, one potassium, and for charge balance, 2 chlorides. All of these are going to get reabsorbed from the filtrate. Now, this potassium that got reabsorbed is actually going to do what's called back leaking, or leaking back out through these channels known as Romke channels. So this potassium is going to leak back out into the lumen, which means that we're going to have a little charge problem because our lumen is going to have a net positive potential because our cation leaked back out. So to deal with that and fix it, we have to reabsorb more cations, and the cations that are going to get reabsorbed are calcium and magnesium, and they're going to get reabsorbed through what's known as paracellular reabsorption. So that means from in between the cells. So they're not going to use specific channels. They're going to kind of just follow a charge gradient and be reabsorbed. So an indirect consequence of this NKCC is going to be calcium and magnesium reabsorption, and that's because the potassium leaks back out. And so to make the charge and everything neutral, calcium and magnesium have to get reabsorbed paracellularly. So the net effect of this channel are the following. You're going to get reabsorption of sodium and chloride through this channel, and then you're also going to get reabsorption of the calcium and the mag to offset the charge balance because the potassium leaked right back out. Now, this sodium and chloride reabsorption is actually going to settle in the interstitial space of the medulla, and particularly in the deep part of the medulla. So let me show you what that looks like right here. So let's get back to our big nephron picture. So as this sodium chloride is being reabsorbed from the thick ascending limb, it's actually going to leak through these peritubular capillaries because they have wide fenestrations between their endothelium, and they're very angulated, so they're going at a slow rate. And so this sodium chloride is going to then end up dispersing all throughout the medulla everywhere. So all of this sodium chloride that you see everywhere here in the medulla, that all came from the thick ascending limb through this NKCC transporter. So the important thing about this NKCC transporter is that by reabsorbing the sodium, this is going to cause what's known as a hypertonic medulla. That means that the medulla has increased tonicity or increased osmotic pressure, and the deeper you go in the medulla, the greater this osmotic pressure is. So why this is important is because this hypertonic medulla is going to create an osmotic gradient, which is going to pull water out of the filtrate through the descending limb, because the main thing that moves out in the descending limb is water. It's impermeable to ions, as well as in the collecting duct. And so the ability to concentrate our urine by pulling water out of it is all set up by the gradient that was created by the NKCC transporter. And the reason that I'm belaboring this is because we're going to talk about the diuretics that inhibit this transporter, and these are known as the loop diuretics, and we're going to see what the consequence of these diuretics are by inhibiting the creation of this hypertonic medulla and the osmotic gradient. All right, so now let's talk about these loop diuretics. The main drug here is furosemide, otherwise known as Lasix. Their mechanism of action is that they're NKCC inhibitors, so they're going to inhibit NaCl reabsorption, and therefore they're useful in treatment of hypertension. They're also going to reduce calcium reabsorption, because remember, calcium and magnesium reabsorption here was secondary to the actions of NKCC. So if we're inhibited here, we're not going to have a drive for reabsorption of these guys, and therefore this is helpful in treatment of patients that have hypercalcemia. So if they have high serum calcium levels, this is going to help them by preventing calcium reabsorption. They essentially pee out more calcium and help reduce their levels of calcium. But the most important indication for loop diuretics, by inhibiting NKCC channels, they're going to inhibit their action in setting up that medullary hypertonicity. Therefore, there's not going to be a interstitial osmotic drive for water reabsorption into the descending limb and the collecting ducts. So it's going to essentially just pee out very highly diluted urine, and therefore it's going to get rid of large volumes of water from the body, and therefore they're very helpful for treatment of conditions that cause edema, like congestive heart failure and cirrhosis. So that's the main indication for these drugs, and that's because they directly inhibit the setting up of that osmotic gradient in the medulla. So now let's talk about their side effects. So of course, they're going to cause dehydration, and that's because they can lead to excessive dilution of the urine. Remember, we just talked about it here. You lose the ability to reabsorb water from the filtrate. Therefore, you lose a lot of water and you can get dehydrated. They can also cause hypocalcemia. So by impairing this calcium reabsorption, they can lead to losing of too much calcium. So you can have the opposite problem now, and you can get hypocalcemic. And one mnemonic that's always been helpful is loops lose calcium. And this is a good way to distinguish the loop diuretics from the thiazide diuretics, which we're going to talk about next. For the same reason as the hypocalcemia, they can also cause hypomagnesemia, because that was the other cation that would get absorbed here. And then finally, they can cause hypokalemia and metabolic alkalosis, because we have more sodium in the filtrate because it's not being reabsorbed. So more sodium in the filtrate is going to make it to the collecting ducts. We're also going to have stimulation of the collecting duct channels by RAS because of the dehydration. All of this is going to lead to increased action of the ENaC channels, and a consequence of those is going to be increased secretion of protons and potassium in the urine. So serum levels of potassium and protons are going to go down. Therefore, we're going to have hypokalemia and metabolic alkalosis. And then a couple of other high-yield side effects that are associated with loop diuretics. They can cause ototoxicity, for example, ringing in the ears and problem hearing. They can actually damage transporters in the inner ear. This is actually a reversible side effect after you stop using these medications. And then the other important side effect with loop diuretics is that they can cause gout. All right, so let's get back to our nephron and move to our next site where we have sodium reabsorption, and that's the distal convoluted tubule. So again, we're going to zoom in here into our cell. The channels that are important for sodium reabsorption here is known as the NCC. So this stands for the sodium chloride cotransporter. It's a cotransporter. That means both sodium and chloride are going to go in the same direction. They're both going to be reabsorbed from the filtrate from the apical side into the cell and to the rest of the body. So the net effect here is going to be sodium and chloride reabsorption, and the main diuretics that are going to impact this and prevent this reabsorption of sodium and chloride are the thiazide diuretics, which I'm going to talk about next. All right, so let's talk about these thiazide diuretics, and the main representative drug of this class is hydrochlorothiazide. This is also one of the most common medications prescribed in the US, very commonly given for management of hypertension. So the mechanism of action of this drug is that this inhibits the NCC, which is the sodium chloride cotransporter, and therefore by doing this, it's going to prevent reabsorption of sodium and chloride. Now, interestingly, in addition to its mechanism of action, it has kind of an interesting side effect. You may have noticed on the last slide that I also included a channel that has to do with calcium reabsorption. So this is known as the TRPV5 channel. So what happens is that via this channel, calcium gets reabsorbed from the filtrate into the cell to the rest of the body. And what happens here is that these thiazide diuretics upregulate TRPV5, therefore they're going to lead to an increase in calcium reabsorption. So the main effects of these thiazide diuretics, just to recap, is that they're going to decrease NaCl reabsorption. Obviously, that's their mechanism of action. Therefore, they're used for treatment of hypertension and edema. Additionally, because they're going to also increase calcium reabsorption through this TRPV5 channel, they're going to be helpful for treating hypercalciuria and calcium kidney stones, because they're going to lower the levels of calcium in the urine. Therefore, they're going to be helpful for the treatment of this condition, and also resolving calcium kidney stones, because there's going to be less calcium now in the urine to form stones. And they can also be helpful in patients that have osteoporosis, because they're going to help increase calcium levels, which can improve bone density. So now let's talk about the side effects of the thiazides. So their main side effects are hyponatremia. Hyponatremia is low sodium levels in the blood that can happen with any of these diuretics, but the most common ones are the thiazide diuretics. They can also cause hypercalcemia because they're going to increase calcium reabsorption. They can also cause hypokalemia and metabolic alkalosis. This is the same exact mechanism with the loop diuretics, increase activity of the ENaC channels in the collecting ducts, which are going to lead to proton and potassium secretion. They can cause hyperglycemia, hyperlipidemia, and both of these are risk factors for cardiovascular disease. So you have to carefully monitor their blood glucose and lipid levels. And then finally, just like loop diuretics, they can cause hyperuricemia and lead to gout. All right, so let's talk about our final place where we have sodium reabsorption, which is the collecting duct, and that's also the final part of the nephron. So if we zoom in here, we see that we have two cell types. We have the principal cells, and those are the main cells in the collecting duct. And we also have intercalated cells. There are alpha and beta, and the main one for this discussion is the alpha intercalated cells. So how does sodium reabsorption work? Well, it works through these ENaC channels that I've been talking about. So ENaC stands for epithelial sodium channels, and that's these guys right here in the gray. So they're located on the apical side, so they're facing the lumen, and what they do is they increase sodium reabsorption from the filtrate back to the body. Now, these channels are not expressed at the same level all the time. They're actually activated by aldosterone. When the body is hypovolemic or has low blood pressure, it leads to activation of the RAS pathway, and aldosterone is going to come here to the collecting ducts, bind its intracellular receptor inside of these principal cells, and lead to upregulation of the production and placement of these ENaC channels on the apical membrane, and therefore increase sodium reabsorption. And by doing this, it's going to restore fluid and blood pressure up back towards homeostasis. So the direct effect of these ENaC channels is to increase sodium reabsorption. But what's going to happen as a consequence of removing these cations from the filtrate is now our apical lumen is going to be negatively charged. So to compensate for that, we have to secrete cations back into the filtrate. And the way we do that is by secreting potassium and protons. So the potassium is going to be secreted through the ROM-K channels in the principal cells. The protons are going to be secreted through the proton ATPase, through the alpha intercalated cells. So the overall effect is going to be increased sodium reabsorption, and then a secondary secretion of potassium and protons. And next, I'm going to talk about the diuretics that affect these channels, and these are known as the potassium-sparing diuretics. All right, so now let's talk about these potassium-sparing diuretics. There are actually two types that fall in this category. The first ones are aldosterone antagonists, so they prevent aldosterone and mineralocorticoids from binding this receptor. The next ones are one step further in the pathway, so they're direct ENaC inhibitors. The main drugs that are in each class I've listed here. So for the aldosterone antagonists, Spironolactone and Eplerenone, both of these end with "-one", just like aldosterone. The ENaC inhibitors, which are the ones that are directly inhibiting this channel right here, those are Amiloride and triamterene. Now you may be wondering why all of these are known as potassium-sparing diuretics. Well, let's think back to the other diuretics we talked about, the carbonic anhydrase inhibitors, which worked at the proximal convoluted tubule, the loop diuretics, and the thiazide diuretics. The effect of all of those on potassium was hypocalcemia, because what they did was they caused increased sodium delivery to the collecting duct and increased action of ENaC, which then led to loss of potassium and hypokalemia. These diuretics are working directly here and inhibiting the ENaC action. Therefore, you're not going to get hypokalemia. If anything, you might get hyperkalemia. And since you're not losing potassium with these diuretics, that's why they're known as potassium-sparing diuretics, to distinguish them from the other three classes we talked about before, which were potassium-losing diuretics. So that's an important concept to remember. Now, the main uses of these drugs are for cases where you have hyperaldosteronism, such as Conn's syndrome, where you have a hyperplasia of the aldosterone secreting cells. Also, in some cases of cirrhosis, where you have ascites, congestive heart failure, and also rarely in treatment refractory hypertension, these medications can be used. Typically, they're used in combo with the other diuretics for the potassium balance. So that makes sense because those other diuretics cause hypokalemia. These ones can potentially cause hyperkalemia. So if you use them together, you might be able to get a potassium balance there and normal potassium levels. Spironolactone also has anti-androgen properties and therefore is a standard part of the treatment for patients with polycystic ovarian syndrome. Now let's talk about side effects, and these make sense. So of course, hyperkalemia, because you're going to inhibit potassium secretion. Similarly, metabolic acidosis, because you're going to prevent the ability to secrete protons through this proton ATPase, which is a consequence of the ENaC channel activity. And then finally, with spironolactone itself, in males, it can cause gynecomastia. All right, I wanted to bring up a topic that I always found confusing, and I think many students do. The question you might be asking yourself is, why don't all diuretics cause hyponatremia always, since they're reducing the amount of sodium in the body? We all agree that's their main function. And in order to understand that, we have to define what we actually mean by hyponatremia. So when we're talking about hypo and hypernatremia, we're not talking about just the content of sodium in the body. We're talking about the levels in the plasma. So that's the ratio of sodium over the volume of water. That's really key here. We have a denominator here, which is the volume of water inside of our plasma. And the normal ratio is 135 to 145 milliequivalents of sodium over liters of water. So hyponatremia is specifically defined as a low sodium concentration, so less than 135, and hypernatremia is greater than the upper limit, so 145. So that means that in hyponatremia, we have a low sodium to water ratio, and in hypernatremia, we have a high sodium to water ratio. Again, the point being that the sodium is not the only determinant here. What's really important is our denominator, which is the volume of water in our plasma. And in fact, this is the main thing that's going to determine whether we have hypo or hypernatremia. So we know that diuretics decrease the total body content of sodium, therefore the plasma levels are going to go down. But we know that the secondary action to that is also water loss. So they're also going to decrease the volume of water. So whether these diuretics are going to cause hyponatremia or not is going to depend on the ratio of the sodium loss versus the water loss. So for example, if our sodium loss is equal to the water loss, so if the diuretic causes the patient to lose just as much sodium as water, then the ratio is going to remain normal and the sodium levels are going to remain normal. So we're not going to have hyponatremia. And this is the case most of the time when the patients are taking most diuretics. On the other hand, if the diuretic causes more sodium loss than water loss, then we're going to have a decrease in our ratio and therefore hyponatremia. The most common culprit of these are the thiazide diuretics. The other condition where you normally see this hyponatremia with taking diuretics is if someone is also drinking a lot of free water. So they're taking diuretics and they're losing sodium and water. On the other end, they're just drinking excess free water. This is going to dilute their plasma and lead to hyponatremia. So the bottom line with hyponatremia and diuretics is hyponatremia is the most common electrolyte abnormality that you're going to see. And most of the time it's induced by medications, commonly diuretics, but it's not going to happen all the time with diuretics. And the main culprit are the thiazide diuretics. All right, so now we're almost done here. Let's just quickly look back at our overview of the diuretics and the mechanisms. Remember I said that most diuretics work by reducing the serum sodium levels. That was going to be most of this talk, and we already covered that. So these are the four classes: the carbonic anhydrase inhibitors at the proximal convoluted tubule, the loop diuretics at the thick ascending limb of the loop of Henle, thiazides at the distal convoluted tubule, and the potassium-sparing diuretics we just went over, the collecting ducts. So the final thing that's left is the other category, whose mechanism is to not work through serum sodium, but actually act as osmotic diuretic agents and directly pull out water. So I'm going to cover that now briefly. All right, so let's learn about these osmotic diuretics. And the main drug here is mannitol. So this drug is given IV. So in the patient's blood, it's going to increase the osmolarity, and that's going to draw water from the interstitial space into the intravascular compartment. So this is going to reduce the tissue's fluid volume, and it's going to get rid of any kind of edema in the tissues. As this blood circulates around and goes to the kidneys, mannitol is going to get filtered at the glomerulus, and it's going to end up in the filtrate. But this medication is not reabsorbed, so it's going to remain in the filtrate. And because it is a very strong osmotic agent, it's going to then increase the osmolarity of the filtrate, and so it's going to draw even more water from the blood into the urine, into the filtrate, which is going to further increase its effect as a diuretic. So the main side effects here are dehydration because of the removal of large amounts of water. It can also counterintuitively cause heart failure because one of the first things that happened here, remember, was that we had rapid water shifts from the interstitial space into the intravascular compartment. So all of that water suddenly shifting into the intravascular compartment can actually overwhelm the heart and cause heart failure. And it can also cause significant electrolyte abnormalities due to rapid water shifts. And for all of these reasons, this medication is very, very rarely used. So this is not a common agent. Really, the main indication that I've ever given it in the emergency department is for treatment of cerebral edema, which is increased intracranial pressure. So say someone has a head injury or some other cause for edema in their brain, and you want to reduce the tissue fluid volume around the brain and reduce the edema. Mannitol can be effective in doing that. Another indication is to reduce intraocular pressure for similar reasons that it can draw water out of tissues. So here's our summary slide. And when we're talking about diuretics, we only have one class that is an osmotic diuretic, and that's mannitol. All the rest of them work by reducing the sodium levels, by preventing sodium reabsorption in the nephron, so that's everything else. And then my first branch point is potassium. So we have one category which are potassium-sparing, so as a potential side effect, they can cause hyperkalemia. And the two main categories there are the aldosterone antagonists, which both end with -one, and the ENaC blockers, which directly block these channels. On the other hand, the potassium-losing ones could cause hypokalemia, and the next branch point among these is acid-base balance. So one of these can cause metabolic acidosis, and those are the carbonic anhydrase inhibitors, and that's acetazolamide. The other two categories here, which are the loop diuretics and thiazides, would cause metabolic alkalosis. Among these two, the way that you can distinguish is based on the effects on calcium. So remember, loops lose calcium, so they can cause hypocalcemia, whereas thiazides upregulate the calcium reabsorption receptor, so they can lead to hypercalcemia. And then the final point here is that all the drug names that you see here that are in pink have sulfa components, so you have to use with caution in patients who have sulfa allergies. Okay, that's it, and that's all. I'll include the link to a couple of relevant videos here for you to check out. If you guys enjoyed this video, don't forget to like, comment, and share it with others, and also consider subscribing to this channel so you don't miss out on upcoming content. But for now, thanks for watching, and I'll see you next time.